Welcome to our sketch on vulvovaginitis. There's nothing like taking a walk in the Big Apple. You can see anything if you stroll around long enough. Like, look at these flowers over here. I've never seen any flora that looks quite like them. The majority look good, but the minority look like there's something a bit off. Vulvovaginitis is inflammation or infection of the vagina. It's one of the most common reasons women present to their OBGYNs. We're going to represent vulvovaginitis with these vulva flowers with the red centers that are looking a little bit inflamed in the middle. Vaginitis is usually caused by a shift in the normal vaginal ecosystem. What's normal, you ask? Bacteria is normal. But don't fear. These are good bacteria that produce lactic acid and hydrogen peroxide, which help deter more harmful bacteria from colonizing. When the normal vaginal bacterial balance is altered, it sends the whole ecosystem into a tailspin. I wonder if that's why this flower shop has put up this "Do Not Disturb Our Ecosystem" sign. Seems like it's a little too late for these poor petunias. One marker of vaginal health is vaginal pH. A normal vaginal pH is between 4 and 4.5, which is a reflection of the amount of lactic acid made by the lactobacilli in the vagina. The substrate for lactic acid production is glycogen, so the more glycogen, the more acidic. This is important because after women go through menopause, there's far less glycogen in the vaginal epithelium, and therefore less lactic acid production. The typical vaginal pH for menopausal women is between 6 and 7.5. While there are many causes of vaginitis, which will later split into infectious and non-infectious causes, most women will come in with a characteristic constellation of symptoms, which we've symbolized and placed around our vulvovaginitis flowers. These patients will come in complaining of vaginal itching, which we'll represent with this itching dog, burning, represented by this burning trash can, vaginal odor, which we'll remind you of with these smell lines coming from the burning trash, and abnormal vaginal discharge, symbolized here with this leaking fluid. She may also complain of dysuria, represented by this dog peeing on a fire hydrant, and dyspareunia, symbolized by this discount petunia store. All patients that come in with these symptoms get the same workup. While we'll go over the workup in full a little later in this sketch, we're going to review a few key tests that you only really encounter when you suspect vaginitis. All of these tests are collected during the sterile speculum exam portion of your pelvic exam. The first test you want to do is a test of the vaginal pH. You'll do this by either taking a swab from the vaginal wall and applying it to some pH paper, or by placing the pH paper itself on the side of the vaginal wall. This 4th and 45th flower shop will remind you that the normal vaginal pH is between 4 and 4.5. Next, you're also going to take a swab of the vaginal discharge you see. Then you're going to smear it on a slide and add a few drops of normal saline to it. This is called a wet mount. Now brush off those pre-med microscopy skills and take a look at that slide under the microscope. You're looking for any signs of infection. Note white blood cells, organisms, a little more on those later, and the types of cells that you see. You're not done with that slide yet. Now you're going to take out some potassium hydroxide, or KOH, put a few drops on the slide, and perform 2 more tests. The first is the whiff test, which, well, is exactly what it sounds like. Waft some of those volatile amines up your nostrils. Smell them? Well, you've got yourself a positive whiff test. Don't smell them? Well, either it's negative or you better get yourself checked out for Cartagena syndrome. But I digress. Now back to the microscope. The KOH should have destroyed all cellular elements, making it easier to see budding yeast or pseudohyphae, represented by these buds and branches. Okay, now that we have the basics of testing down, let's go over the different etiologies of vaginitis. As we mentioned before, we're going to divide these up into infectious versus non-infectious causes. Let's start with infectious, where you'll encounter 3 main causes: Candida, bacterial vaginosis, and trichomonas. Candidal infections of the vagina are usually caused by Candida albicans, which you may remember is a fungus, specifically a yeast. We'll represent Candida with this Candida snow shop. Is it just me, or do those jackets look like they'd be a little itchy? In these infections, the most striking symptoms patients complain of are vaginal itching and thick white discharge, which may resemble cottage cheese. which this pile of snow looks a lot like too. Common risk factors for vaginal candidiasis are recent antibiotic use and poorly controlled diabetes, which are symbolized here on the snowboard by the pills and candy. Really, any immunosuppressed state, such as HIV, is a risk factor for a candidal infection. So we have this mannequin holding a crutch, a recurring symbol for immunosuppression. Unlike in the other infectious causes of vaginitis that we'll cover, candidiasis does not cause a change in vaginal pH. So the pH should be in the normal range of 4 to 4.5, which you'll remember from the 4th and 45th flower shop next door. During your workup, you'll do a potassium hydroxide preparation on your wet mount, which will show either budding yeast or pseudohyphae, because Candida albicans is a dimorphic fungus. We'll represent the pseudohyphae here with the branching water pattern on the window, but we've also provided a real live slide of pseudohyphae and budding yeast so that you know exactly what to look for. The treatment for Candida vulvovaginitis is oral fluconazole, represented by this pine cone hanging by the mannequin with an open mouth. If the patient is pregnant, use vaginal clotrimazole or meconazole, symbolized by these cones by this pregnant mannequin. The next infectious cause is bacterial vaginosis, or BV as it's often called. In this condition, there's a shift in vaginal flora that causes anaerobic species overgrowth. We'll represent BV as Gino's Fish Garden, your neighborhood stop for all your pescatarian needs. The typical organisms found as the culprits of bacterial vaginosis are Gardnerella vaginalis and Ureaplasma ureolyticum. These patients are going to come in complaining of thin, gray, fishy-smelling discharge. Although BV is not classified as an STI, a major risk factor is being sexually active. Like these love fish over here. For BV, there are specific clinical criteria, known as Amsel's criteria, that have to be met in order to make a diagnosis. The 4 criteria, represented by the 4 damselfish for sale, are as follows. The first is thin, white, gray, or yellow discharge, like the discharge coming out of this first fish here on the left. Next are clue cells on wet mount, which are epithelial cells covered in bacteria. In the sketch, we'll represent them as this question mark-shaped water droplet over our second fish, but here's a picture to get a better idea of what clue cells look like under the microscope. The third criteria is a vaginal pH greater than 4.5, which is above the normal pH and is symbolized by the price of these fish at just over $4.5. And finally, a fishy odor noted on the whiff test, which is when you take a big ol' whiff of the slide after applying KOH, which causes the release of volatile amines produced by anaerobic metabolism. How long has this last fish been sitting out for? The treatment for BV is oral or vaginal metronidazole or clindamycin. It's okay to use either of these in pregnant women, which is why this pregnant lady is walking calmly past the Keep Clean poster and into this metro stop. The final infectious cause of vaginitis is trichomoniasis, which is an infection caused by the protozoan Trichomonas, symbolized by our street magician who's performing a wonderful trick for us. These patients typically complain of a foul-smelling yellow-green discharge. I wonder why this magician picked such a smelly spot to do his tricks. Maybe it's the lighting from that yellow-green street lamp? Since Trichomonas is a sexually transmitted infection, risk factors for contracting it include being sexually active and not using barrier protection. On exam, you'll see this yellow-green discharge and may also see strawberry spots, which are subepithelial hemorrhages along the vaginal epithelium and cervix. This trickster seems to be pulling a strawberry out of a cervix? I've never seen that one before. And that's New York City for you kids. These patients will usually have an elevated vaginal pH between 5 and 6. On the wet mount, you'll see a little creature, a trichomonad. These little buggers look like, well, bugs. They're oval-shaped and have a flagellum protruding from one end, as you can see in this puddle and on this slide. The treatment for trichomoniasis is oral metronidazole, which, as you may remember, is okay to use in pregnancy. If you diagnose trichomoniasis, make sure to have the patient's sexual partner treated too. If you don't, your patient is going to make like a magician and have that trichomonas reappear. Ta-da! Now moving on to the non-infectious causes. There are 3, which is a nice parallel to the infectious causes. They are atrophic vaginitis, vaginal foreign body, and desquamative inflammatory vaginitis. Atrophic vaginitis is caused by low estrogen states, represented by this dried up, atrophic appearing laundry. Low estrogen, represented by this drooping flower, our recurring symbol for estrogen, causes a thinning of the vaginal epithelium. Since atrophic vaginitis is caused by low estrogen, it makes sense that it's found in women with low estrogen. The most notorious of these ladies are those who are postmenopausal, but really, any low estrogen state puts you at risk for atrophic vaginitis. These patients will complain of vaginal dryness, irritation, and dyspareunia. They also may note a watery, foul-smelling discharge as well as urinary urgency and frequency. On exam, you'll note a much paler, whiter vaginal epithelium, represented by this white plaster on the building's wall, as well as a loss of vaginal rugae. The vaginal pH will be higher than normal, so above 5. The wet mount will show parabasal cells, which are immature squamous epithelial cells notable for their large nucleus to cytoplasm ratio, as well as PMNs. The treatment for atrophic vaginitis is topical vaginal estrogen therapy, represented by this estrogen flower in front of this lady's pelvis. Another cause of non-infectious vaginitis is a vaginal foreign body, represented by this couch in the doorway of the Foreign Lands Travel Agency. These patients will present with malodorous vaginal discharge as well as occasional vaginal bleeding, which is why this couch smells and seems to have some bloodstains on it. What's going on in there? Vaginal foreign bodies are usually found in prepubertal girls, especially toddlers, who may put a foreign object into their vagina. On exam, you'll find a foreign body, and treatment is easy. The treatment for this condition is to remove the foreign body, just like this guy is removing this couch. The final non-infectious cause of vaginitis that we'll cover in this sketch is desquamative inflammatory vaginitis, or DIV, represented by this taxi that has burst into flames, flinging chips of its paint into the street. The exact cause of DIV is still unknown, and it's a diagnosis of exclusion, which means you should rule out every other cause of vaginitis we've reviewed so far. But its typical features are as follows. This condition is marked by a copious amount of watery vaginal discharge that can be yellow, gray, or even green. This discharge is due to the desquamation of the vaginal epithelium. These patients also complain of vaginal and introital pain, kinda right in the area this taxi driver seems to be hurting. The typical demographic for desquamative inflammatory vaginitis is perimenopausal women, which is why this cell phone is on pause. Hey, was this taxi driver watching a video while driving? That is not cool. On exam, the vagina can show spotty focal erythema. As for studies, the vaginal pH will be increased, usually above 4.5, and the wet mount will be similar to that of atrophic vaginitis, increased parabasal and inflammatory cells. As DIV is a diagnosis of exclusion, it's important to rule out any infectious causes for the symptoms, so there should not be any signs of infection on labs. The treatment for DIV is either vaginal clindamycin, represented by this Don't Litter, Keep Clean flyer that ironically seems to have become litter itself, or vaginal glucocorticoids, represented by this moon hubcap. Although we've covered the key tests and findings for infectious and non-infectious causes of vaginitis, let's quickly review what you should include in a full workup. Anytime a woman presents with symptoms of vaginitis, you're going to do a full H&P while focusing on the following. Make sure to take a full sexual history, noting any known history of sexually transmitted infections or partners with sexually transmitted infections. You're also going to want to assess their menstrual history. Are they perimenopausal? Menopausal? Note any changes in bleeding patterns. In terms of the physical exam, make sure to do a full pelvic exam. This includes a complete inspection of the external genitalia as well as a sterile speculum exam inspecting the vaginal canal and cervix. You'll also want to note if there's any inflammation, the color and consistency of vaginal discharge, and if you see any lesions or foreign bodies in the vaginal canal. Part of your pelvic exam is also your bimanual exam. With this, you'll assess for any pain or masses in the female reproductive organs, which would make you suspicious for something going on besides vaginitis. As we reviewed before, you'll get a battery of tests, which include a vaginal pH, vaginal swab of the discharge from which you'll make a wet mount with 0.9% saline and then examine under the microscope, a KOH prep on this swab, and a whiff test. Finally, all women who present with symptoms of vaginitis should also get tested for gonorrhea and chlamydia. Up to a quarter of those who test positive for bacterial vaginosis or candida also test positive for a sexually transmitted infection. You can test for gonorrhea and chlamydia via nucleic acid amplification tests, either via cervical swab or urine test. NYC never disappoints. What did our fair city teach us today? We learned all about vaginitis, which normally presents with vaginal itching, burning, odor, abnormal discharge, dysuria, and dyspareunia. First, we went over the infectious causes of vaginitis, starting with Candida vulvovaginitis caused by Candida albicans. Patients with candidal infections will complain of a lot of itching and thick, white, cottage cheese-like discharge. Risk factors for Candida vulvovaginitis include recent antibiotic use, poorly controlled diabetes, and immunosuppression. Unlike the other causes of vaginitis, vaginas infected with Candida have a normal pH of 4 to 4.5. The KOH wet mount will show pseudohyphae and budding yeast. Treatment for Candida vulvovaginitis consists of oral fluconazole or vaginal clotrimazole or meconazole for pregnant women. Next up for infectious causes was bacterial vaginosis. These patients complain of a thin, gray, fishy-smelling discharge. The clinical criteria to diagnose BV are called Amsel's criteria, which are thin, gray discharge, a wet mount showing clue cells, an elevated pH above 4.5, and a positive whiff test. The treatment is metronidazole or clindamycin, both of which are okay to use in pregnant women. Rounding out our trio of infectious causes is trichomoniasis. These patients complain of yellow-green, foul-smelling discharge. On exam, you'll see strawberry spots on the cervix and vagina. The vaginal pH is elevated at around 5 to 6. On wet mount, you'll see the trichomonads themselves. The treatment for trichomoniasis is metronidazole, which is safe in pregnancy. Since trichomonas is an STI, make sure to treat your patient's partner too. After infectious causes, we went over the non-infectious causes of vaginitis. The first was atrophic vaginitis. This is most commonly found in women with low estrogen, such as postmenopausal women. On exam, you'll see loss of vaginal rugae and pale whitish vaginal epithelium. The wet mount will show parabasal cells, which are immature squamous cells with a large nucleus to cytoplasm ratio. You'll also see a lot of inflammatory cells. The treatment for atrophic vaginitis is topical vaginal estrogen. Second on our list of non-infectious causes are vaginal foreign bodies. These patients are usually prepubertal girls who complain of malodorous vaginal discharge and some vaginal bleeding. The treatment is to remove the foreign object from the vagina. Finally, we have desquamative inflammatory vaginitis. These patients complain of a copious amount of watery vaginal discharge and vaginal pain. Exam will be notable for a spotty rash or focal erythema within the vagina. The wet mount will show increased parabasal and inflammatory cells. And finally, treatment is vaginal clindamycin or vaginal glucocorticoids. Well, what'd I tell ya? There's no place like NYC. Now, if you'll excuse me, I've got a cab to catch. Until the next time that itch comes around.